afternoon, everybody. My name is Reem Hamdy, as the chairman presented me, and my talk is going to be about B-cell targeted therapy in rheumatology practice. And being a rheumatologist, my points of concerns are immunity and autoimmunity, and I'm looking all the time for targets to treat my patients and achieve remission in refractory disease. So I have always to be minded with what is autoimmunity and how should I manage, which is a state of an abnormal biological response to self-antigens leading to initiation and escalation of a self-directed immune attack with subsequent organ damage. And under normal circumstances, the human body had regulatory mechanisms to avoid these problems, and it starts as early as during the lymphocyte. Can I use this? Okay.
Is that the dead one? I'm sorry, I don't have one.
Okay.
Yes.
Yeah, it's functioning. Yeah. As we see here, these are the mechanisms implicated in self-tolerance, or what we say early immune regulation, where any lymphocyte at the immature stage that gets into recognition of our self-antigen handles or gets checked out through apoptosis, which is deletion of the autoreactive lymphocytes, or some sort of receptor editing, where the cells having receptors capable of identification of self-antigens, they get some sort of editing to the receptor to be non-reactive to self-antigens, or the development of regulatory cells during the early developmental stages for these lymphocytes. This is what we call the central tolerance, or the central checkpoint. And then we have a peripheral checkpoint that occurs in the peripheral tissues, where the ones that skip the central tolerance, they meet another checkpoint, and they are then subjected to energy. Energy means blinding of the autoreactive lymphocytes so that they are incapable of seeing your self-antigens, or apoptosis, which is deletion or suppression via the regulatory mechanisms through either regulatory T lymphocytes or the B lymphocytes. Any disruption in any of these mechanisms leads to the evolution of identification of self-antigens and a self-directed biologic attack that contributes to the development of autoimmune diseases. It's usually multifactorial, in which the cell-mediated response and the humoral-mediated response are involved in the pathogenesis. And speaking of my target today, which is the B lymphocyte, the B lymphocyte is considered as the antibody-producing cell. However, it's not only restricted to the humoral arm, it extends its function towards the cell-mediated arm, where the B lymphocytes can activate the T lymphocyte by acting as an antigen-presenting cell, and co-stimulation for the T lymphocytes for their priming to act as effector helper T cells. So we have the B cells acting solely as the mother of the antibody, producing the effector B lymphocyte and plasma cells that lead to the production of antibodies, and memory B cells, which contribute to the continuous lifelong pool of antibody and activation of the T lymphocytes to be effector cells. Therefore, the B lymphocytes can contribute to autoimmunity in a variety of ways. A hyperactive B cell status with defective regulatory function can therefore break down self-tolerance, and there's a large body of evidence that supports the potential pathogenic role of these B lymphocytes in autoimmune diseases. Amongst these, we have the rheumatoid arthritis, as our Hazel spoke early in the morning about rheumatoid arthritis and biosimilars, rheumatoid arthritis, systemic lupus, Sjogren, thrombocytopenic purpura, ANCA-associated vasculitis, and immune complex-mediated leukocytoclastic vasculitis, amongst others. So this sets the B cell as one of my potential targets for intervention, and this mandates understanding the different developmental stages and what are the cell surface antigens involved in the pathogenesis, so that I might go directed towards this to have some sort of an efficient response in my refractory patients. And in the field of rheumatology, we have a number of cell surface antigens that have been identified, and towards which a number of monoclonal antibody therapy have been created. In 2008, we have announcement and guidelines regarding the management of rheumatoid arthritis provided by the American College of Rheumatology. And in these guidelines, we had the rituximab, which was the anti-CD20 monoclonal antibody, approved as the first anti-CD20 B-cell targeted therapy for the management of patients with rheumatoid arthritis. In 2008, the drug was approved the drug was actually approved as a second-line biologic in case of failure of the tumor necrosis factor inhibitor therapy. However, in 2012, we received an update so that we can use the rituximab as a B-cell targeted therapy as a first-line biologic in patients with refractory disease. So what's the CD20? The CD20, it's a transmembrane phosphoprotein that's involved in a variety of functions. It's expressed, as we see, on the surface of the pre-B cells until the late plasmablast cells. It's not on the pro cells or the mature plasma cells or the antibody-producing cells. It appears to play a crucial role in the B-cell development and differentiation. It highly correlates with the complement-dependent cytotoxicity of the B lymphocytes, and overexpression of the CD20 has been illustrated in B-cell-mediated diseases. CD20 acts as a signaling molecule to trigger apoptosis and complement fixation when engaged with its monoclonal antibody. So we can induce apoptosis of the B lymphocytes when we combine the CD20 molecule with its monoclonal antibody. And that's why we had rituximab, the first-generation anti-CD20 monoclonal antibody, as an approved drug. This is a chimeric molecule, human murine monoclonal antibody, and it's recently approved. It has been approved in rheumatoid arthritis in March 2006 for the use in refractory disease, either as a single drug or in combination with conventional DMARDs. And it's usually preferred in patients with seropositive profile in which the autoantibody titer is high. This is an overview of the clinical studies that led to the approval of rituximab. The most important were the Dancer and the Reflex trials that were followed by approval of rituximab because they showed efficient ACR responses at the week 24 and efficient reduction in the disease activity score at the week 24. In the Dancer trial also it was achieved for the primary endpoint regarding the disease activity index and the ACR responses. Furthermore, this was associated by significant reduction in the immunoglobulin level in both categories. And the adverse events were actually not that significant compared to the placebo group. And when they followed the biopsy changes, they found that the use of the anti-CD20 therapy using rituximab induced some sort of lymphoid follicular regression in the synovial tissues. Rituximab was also assessed in the lupus in a variety of ways. First of all, as an induction therapy. And then in specific population, like in patients with severe renal lupus, and in specific racial groups, like in blacks. And now it's being assessed as salvage therapy in addition to plasma pheresis. Actually, we have a lot of reviews in this regards, and most of them are satisfying, apart from the two randomized trials that are the Explorer and the Lunar trials, that went out with the conclusion that it didn't show any significant results compared to the conventional drugs. And by reviewing these two trials, we found that there were some deficits in the populations included, like they included patients with severe disease taking a number of immunosuppressive drugs to the maximum doses. And the two groups included in both studies, they were actually non-comparable and they were non-homogeneous, so we couldn't come with fixed conclusions. And so from 9 uncontrolled studies in lupus, we have seen that the resorption of immune deposits in membranous nephropathy was achieved with rituximab. Response rates with rituximab might last for 1 year, with 1/3 of the patients treated not requiring additional immunosuppression. And in fact, in aggressive disease, despite being off-label, you might use cyclophosphamide, and it might induce successful remission in patients receiving both cyclophosphamide and rituximab in refractory renal illness. This is a publication by the ACR, and these are the treatment guidelines for patients with lupus nephritis. The drug hasn't been FDA approved for the lupus nephritis yet. It's there in the ACR recommendation for the management of refractory disease, as we see here, for the induction therapy and not as a maintenance therapy. So you can use rituximab for the induction of remission in patients with refractory disease in case of failed conventional DMARDs and pulse therapy in these patients. Rituximab has been also tried in vasculitis in 2 big trials, the RAVE and the rituxivas trials, and these trials showed that rituximab was non-inferior to cyclophosphamide therapy in patients with refractory disease, but we had some bending questions like how many times should we repeat the infusions, and should we combine the treatment with basic immunosuppressive drugs or not, and what happens in case of relapses, and so on. So now we are having Reem trial. It's supposed to end in December 2016, and this trial aims to find out whether repeating rituximab stops vasculitis relapse in these people, and whether it works better than older treatment like azathioprine or methotrexate or not. And it will also tell us how long patients remain in remission after repeated rituximab treatment are stopped. It will also assess the safety of the drug. So we are awaiting the results in 2016. In cryoglobulinemic vasculitis, rituximab has been used for refractory disease in patients with HCV, and it has a good safety profile in these patients. In fact, rituximab combined with BEG interferon ribavirin deleted both virus-dependent and independent B-cell clones. And as we know, one of the challenges in the HCV infection is that we have polyclonal B-cell expansion, but leads to resistance to the drug therapy itself in the region of HCV treatment, and might lead to the evolution of immune-mediated diseases like cryoglobulinemic vasculitis in these patients. So when using rituximab, actually, studies have shown sufficient good data in this regard. Furthermore, the antiviral therapy in HCV alone decreased the memory B cells, whereas in association with rituximab, the naive B cell population has also been depleted, which have contributed to the effectiveness of antiviral therapy and immunosuppressives in the vicinity of autoimmune diseases. For the hepatitis B, we have case reports, but actually the drug might be associated by a flare of hepatitis and might be fulminant hepatitis, so it should be we should treat the patients with lamivudine at first, prophylaxis, before starting the rituximab therapy in these patients, with careful monitoring even. It has also been tried in a number of autoimmune diseases like inflammatory polymyositis. This is the Biogas registry in 2006. They studied rituximab in a number of autoimmune rheumatic diseases like inflammatory myopathy, and it induced partial remission of muscular involvement with stabilization of pulmonary disease. Also in systemic sclerosis, it improved the Rodnan score and the myofibroblast score within the skin biopsy. In Sjogren, we had some cases, like 16 cases with severe primary Sjogren, that received rituximab therapy with successful depletion of the salivary lymphocyte infiltrate, and this depletion returned to baseline 18 months after the therapy. So, what contributed to this is that with the rituximab, this chimeric monoclonal antibody that is directed to the human CD20 molecule, we had delayed repopulation of the B-cell memory compartment, with reduction in the level of the B lymphocytes to almost 50% of the baseline values that might last for as long as 2 years from treatment. Rituximab treatment led to effective B-cell depletion in the spleen and the bone marrow. And despite the long-term reduction in the memory B-cell compartment, yet it wasn't associated with significant increase in the risk of serious adverse events or infections in these patients. Because the long-lived plasma cells, the CD20 negative cells, they are spared with the rituximab therapy, so we have a lesser risk for infection in these patients. This is my second molecule. It's another anti-CD20. It's a second-generation anti-CD20 drug that's called ofatumumab. It's a human immunoglobulin G1 monoclonal antibody directed to the CD20, and this drug recognizes a precise membrane proximal epitope on the human CD20 molecule that is distinct from rituximab. And this have actually contributed to a very good outcome, which is a slower rate of dissociation from the CD20 target epitope than the rituximab. This subsequently led to the effect that 70% of the drug remains epitope-bound and in function, compared to 30% with the rituximab therapy, which results in greater complement-dependent cytotoxicity and efficient lysis of the rituximab refractory B-cell population. It has been approved for the treatment of chronic lymphocytic leukemia, and in our field, or our point of interest, it has been investigated in rheumatoid arthritis as an intravenous form and a subcutaneous form, and overall 70% of the patients receiving ofatumumab had a moderate or good response according to the ELR criteria at the week 24, and we're still having ongoing studies in this regard. Despite proven to be effective, it hasn't been yet approved for the use in rituximab refractory rheumatoid arthritis patients. Further confirmatory data and studies are pending. Ocrelizumab, this is another CD20 second generation monoclonal antibody. It's a humanized anti-CD20 monoclonal antibody. It has been tried in rheumatoid arthritis and in systemic lupus erythematosus. However, the use of ocrelizumab was associated by significant increase in serious infections in 4 double-blind randomized controlled trials in RA, and also in the trials for the systemic lupus, the BEGIN and the BELONG trials in systemic lupus erythematosus. We had serious adverse events, and therefore, in March 2010, the Roche and Biogen issued their statement to suspend ocrelizumab treatment in the field of rheumatoid arthritis and systemic lupus erythematosus because they found that the infection risk outweighed the benefit of this drug. Then we have the third generation, which is much better than the previous 2 generations, ocrelizumab. This is the one we use in rheumatology practice. Ocrelizumab is a bimetric, and it's a genetically engineered humanized anti-CD20 monoclonal antibody. The aim behind this drug is to provide a higher affinity binding to the low affinity Fc gamma receptor 3A, which has been involved in the refractoriness of the B lymphocytes to rituximab. So I'm now creating a high affinity binding drug that binds to a receptor that has contributed to refractoriness to rituximab. It actually has 13 to 20-fold higher affinity for the CD20 compared to others, and a 6-fold higher antibody cellular cytotoxicity compared to rituximab. These are the studies for the ocrelizumab. As we find, it's demonstrated 3.5 to 8-fold higher antibody-dependent cellular cytotoxicity than rituximab at concentrations lower than that of rituximab. And we have placebo-controlled double-blind phase 1 study conducted in patients with rheumatoid arthritis. There were a total of 11 patients, and we found that B lymphocyte depletion was assessed. There was no apparent negative consequences for this CD20 therapy, and it showed some efficacy. However, we are lacking a lot of data in this issue, and we are awaiting the approval of the drug based on further evidences from trials. This is comparing the efficacy of the 3 generations, the rituximab as the first generation, ofatumumab as the second, ocrelizumab as the third, and we see that the ocrelizumab is superior to both, being genetically engineered drug designed to bind to its receptor in a better way with a higher affinity in spite of the low affinity receptor. So we are actually having some hope in this drug, but we are lacking a lot of evidences. We are waiting 2016 to bring us more data in this regard. Then we have another cell surface molecule, which is the CD20 surface molecule. It's another surface molecule involved in the B cell activation, and it's also involved in the co-stimulation of the T lymphocytes during the B cell T cell reciprocal interaction. And this surface molecule has been actually elevated in patients with SLE, chronic autoimmune diseases, and in certain cancers. It was also found to be expressed on the surface of other cells like the monocytes, the neutrophils, the erythrocytes, and activated endothelial cells. So it appears appealing to target this antibody. And the drug that was actually designed for this was the eprotizumab. Eprotizumab is a humanized monoclonal antibody targeting the CD20 receptor, and it has a long half-life, the same as rituximab. But unfortunately, in spite of all these trials, the drug failed to achieve its primary endpoint, and therefore the trials were suspended and terminated for this drug. Then we move to another point, another surface molecule that's very important, and it's very similar to the CD20 surface molecule. So attacking this molecule also represents a potential target, which is the CD19. It shares the same effective mechanisms, I think.
Any more slides left?
Yeah. I have my laptop, if you want me to get it.
If you would, because it'll probably take a little while to...
Okay, if you allow me for 5 minutes, I'll bring my laptop instead. It's fine.
Put it on there anyway.
I have the charger for my...
You have a charger?
Yeah, but I think we can...
Just going to plug this in.
We've only a few slides left, but I have to finish them.
Just need to...
Okay.
You want to get to your slides and then I'll... Yeah.
What?
Here we go.
Okay. Thank you. That's the CD19 monoclonal antibody. It's still under trial. It's a fully humanized antibody selectively directed to the CD19, which carries a lot from the CD20, so it's supposed to have a similar efficacy and control for the refractory disease. Preliminary data from ongoing phase 1 study in patients with active RA have demonstrated potent B-cell depletion with a single dose of the drug. However, we don't have more data in this regard. Then comes another important potential target, which is the B-cell survival factor inhibitors, the BLyS and the APRIL. They are two transmembrane proteins. The BLyS gets cleaved and activated and binds to 3 transmembrane proteins involved in the B-cell proliferation, maturation, and in the calcium influx into the cells. And the APRIL actually binds to 2, which are the PECMA and the TACI. These are 2 membrane receptors that are similar to the ones for the BLyS. So they are 2 homologs, and they actually lead to polyclonal B-cell activation, differentiation, and maturation. Furthermore, the elevation in the BLyS leads to skip of the B lymphocytes from the checkout points, so they can skip some sort of tolerance, and the autoreactive B lymphocytes might get to mature to be an autoreactive B-cell producing antibody. In contrast, when they tested reducing the available BLyS, they found that reduction in the available BLyS in the circulation leads to more rigorous selection of the mature B lymphocytes and reduces autoimmunity. On the other hand, we have the APRIL also upregulates the co-stimulatory molecules on the B lymphocytes and therefore enhances their antigen presentation potential. For the BLyS, or the B-cell survival factor, we have the belimumab. This is the Benlysta. It has been approved in the field of systemic lupus erythematosus. Benlysta was found to reduce the antibody production by a reduction in the antibody-producing plasma cells, so reduction in the antibodies, and it enhanced apoptosis of B lymphocytes, depleted the activated and naive B cells as well as the plasma cells, but it didn't have any effect on the memory B lymphocytes, and it specifically binds with high affinity to the soluble BLyS and inhibits its binding to its consecutive receptors, the TACI, the PECMA, and the BAF3 receptor. But the only limitation in this regard is that it does not affect the memory B cell compartment, which is another potential lifelong source of antibodies in the blood. So belimumab has been approved for the use in seropositive patients with systemic lupus erythematosus who have active disease in spite of prior therapies. It can be used as an initial therapy in these patients in addition to anti-malarials and low-dose corticosteroids, and can be used hand-in-hand with intensified immunosuppressive therapy in chronic persistent disease. Then we have another one from the anti-bliss APRIL. This is the atacicept, but atacicept actually has the potential to bind both. It's a fusion protein that binds the receptor for bliss and APRIL, so it leads to selective depletion of the mature and late stages of the B cell development with blocking of the plasma cells, but it spares the progenitor B cells and the memory cells. In fact, experimental studies demonstrated efficacy, and we have human studies in patients with SLE and rheumatoid arthritis that have suggested significant reduction in immunoglobulin G and immunoglobulin M in these patients with refractory disease. But we have the B cell tolerogens. Tolerogens actually aim at some sort of editing for the autoreactive B cells so that the receptors wouldn't identify the self-antigens, and this abitamus, it's the first B cell tolerogen. It was designed for patients with renal and non-renal lupus. It's actually composed of 4 double-stranded DNA epitopes on a polyethylene glycol platform. The drug cross-links with the anti-DNA surface immunoglobulin on the B cells, leading to anergy of the B cells or apoptosis of the B cells, and thereby it significantly reduces the titers for the anti-double-stranded DNA antibodies in these patients. But unfortunately, the ASPEN trial, which is the trial for the abitamus, have been terminated because unexpectedly no benefit was found from the drug. For the itratide, this is another tolerogen that's under experimentation, and the results in this drug hasn't yet been released until the present time. This is a summary for the list of B-cell targeted therapy apart from rituximab. Some of them has been suspended, others are under investigations, and others have been approved, as we discussed before. My conclusions are, for the B-cell targeted therapy, rituximab remains on the top of the list for the B-cell targeted strategies in rheumatoid arthritis. Rituximab is being successfully used in refractory SLE despite being off-label. It's investigated for idiopathic thrombotic thrombocytopenic purpura and bemphigus vulgaris. It's an effective alternative to conventional immunosuppressive failure in refractory ANCA vasculitis. We have belimumab. It's another approved B-cell targeted biologic therapy in refractory SLE. An important point is the targeting of the high affinity, long-lived antibody-forming B cells remains a challenge. I'm speaking about mainly the memory compartment. And because they are not easily tolerized, it's really difficult, as we've seen for the abitamus, despite that it has a high potential for immune suppression and like neutralization of the anti-double-stranded DNA antibodies, yet we had this unexpected failure of the drug. So it's not always easy to target this thing. The need for B-cell tolerizing therapy might open new pipelines for more targeted B-cell intervention. Enhancing regulatory B-cell function is another challenging point in the field of autoimmune diseases. Finally, we might say that the novel strategy of the B-cell target therapy is an encouraging field for research, and the demand for more research is still there. Speaking of biosimilars, we had one biosimilar to rituximab that has been approved for leukemias, but in the field of autoimmune rheumatic diseases, we don't have any sufficient data or approvals yet. Thank you so much for your patience, and I hope I wouldn't have been so monotonous. Thank you so much.
Questions?
For the third one, the anti-CD20, you said it is bind to both CD20 and the Fc gamma R2B.
You're speaking about the ocrelizumab? Yeah.
And how can monoclonal antibody bind to different targets?
It's genetically engineered antibody. They have an Fc and a Fab fragments that are genetically engineered specifically to bind to this low affinity Fc gamma receptor. Because the Fc gamma 3 receptor was one of the problems, the low affinity receptor was one of the problems that have contributed to some sort of refractoriness to rituximab therapy. So meeting this challenge, they are trying to do something else just to overcome these points in patients who are rituximab refractory.
You mean the antibody can recognize both?
Yes.
Be specific antibody.
It's genetically engineered specific antibody to bind to the Fc gamma receptor. Yeah.
And CD20?
It's through the FC. The binding comes through this receptor.
Okay.
How it functions. Okay. So sometimes you do have low affinity of this receptor for binding to the monoclonal antibody. So they overcome this by creating this drug. However, we don't have sufficient encouraging data in the field to push for approval of the drug.
Can I say, do you think the area of bispecifics might help in the future?
Biosimilars?
Bispecifics.
Bispecific antibodies.
Oh, yeah. Yeah, I think. But actually, in the field of rheumatology, we're still talking about what more in the anti-CD20 therapy. And as I discussed before, we're having a lot of problems in clinical practice. You see, you have guidelines, you have freedom to switch, but off-label, and sometimes you report side effects for these biologics that have been extensively used. So I cannot say that the bispecifics might be a definite target for me or something like that, but let's hope for the best. I think if we just increase the field of research in this issue, we might have a lot. But the problem is, it's like it's not a point of focus yet in the field of research. They are just switching from one to another, like changing the menu of your meals. But actually, you're not concentrating on what was the defect in this drug, so that you might retry it again. It's not by increasing the list. It's what's the defect there, so that I can handle. I might go back to one of these drugs that failed the trials, and I can see if I can just modify the drug to achieve something, instead of adding so and so and so and so and saying this was abolished, this was terminated, this had a lot of side effects. So where are the solid data that I can depend upon? We might have, yes, we might. Thank you.
That leads to a couple questions I have, your last comment. One is, if I can remember my thought. It was a very nice review of the current status of some of the results of trials and things. But in the rituximab, I think it mentioned in one trial, I think it was for lupus, that they saw no benefit over conventional therapy.
Yes.
And it was kind of a conclusion. Well, I mean, my question is, what about a savings in side effects from traditional therapy, or contraindications of traditional therapy, or other benefits besides? For the current participants of the trial, there wasn't an improvement in primary endpoint.
Yes, definitely. Because the choice of the patient population actually was defective. You don't have to bring me a patient with a refractory end-stage disease and tell me this drug is going to save the patient. Your patient has been for long with refractory illness and had significant organ damage. In lupus, it's not only a matter of activity, it's also a matter of organ damage. How much the organ has been damaged, and how much you spare. So it's actually not solely effectiveness of the drug, it's the state of the patient. And in this trial in particular, we said one of the drawbacks is that they got very late-stage patients that have been under extensive immunosuppressive therapy. So how can I judge the effectiveness of this drug? Even if I said that it wasn't safe, how come I can say that it wasn't safe and this patient is receiving 2 or 3 immunosuppressives for a long time and still having active disease that in fact contributes to increased risk of infection? So it's not a single way. I think we need more organized trials, and this is one drawback that has been published by the group, because actually at my personal level and in a lot of case studies, as you've seen, and some uncontrolled trials on limited patients, we had satisfying response with the rituximab in SLE, refractory lupus nephritis, in refractory hematologic disease.
Also then, thank you, it's very, very, very helpful. But also you mentioned a few, even concepts such as biosimilars, But you've also mentioned such distinct orthogonal approaches, even to B-cell reduction, not considering memory cells. But what about combination therapies? You went so fast. For me, it's not my field. But what about combinations between orthogonal approaches that might have a synergistic effect? Was that considered?
Well, that's fine. But actually, because of the side effects of this therapy, and because we don't have significant long-term studies, particularly in patients with lupus, who usually show you the unexpected. You always expect something, and then you face some unexpected issues in these patients. We have seen, and it's strictly written in these drugs, that never to combine 2 biologics together. You don't have studies sufficient, and you have sufficient data regarding the safety of the use of some drugs in immunocompromised patients. So combining biologics in the current time is not a safe approach. The only thing that they are recommending in the field of refractory lupus, and I have tried it at the personal level in one case, which is cyclophosphamide and then rituximab, and it actually brought immense benefit, really, in one case. It was one case.
So you can apply small molecule and biological combination.
Yes, I can use the immunosuppressives, whatever I can, with the biologic. But combining biologics together, we have to have studies sufficient to support this. Otherwise, it's contraindicated by American College of Rheumatology.
Well, okay, well, thanks very much. Is there any other questions before we break here? All right. Oh, yeah, go ahead.
Yeah, I was wondering what your position is on immunosuppressants in general. Are we approaching the moment that we can bin them because there are good alternatives?
Well, they are trying to say that they are trying to use that one drug. We need to reduce the risk and we need to minimize the side effects and we need the patient to be compliant and we need the patient. But in practice, in most of the situations, we use combination between the conventional immunosuppressives as a baseline therapy, and then you build up your biologic drug on top, even in rheumatoid arthritis. It's one of the most preferred approaches to use the immunosuppressives, particularly methotrexate, because in addition to efficacy, it reduces the immunogenicity of these monoclonal antibodies that you're using. So it may increase the longevity for the drug usage in these patients. So you're going safe, relatively safe. But the absolute removal, you might do it in some patients. Some patients say, I need one drug only, so I can go for it. However, the preferred way is to use conventional baseline immunosuppressives and build up your biologics on top. It increases the longevity for the use of biologics, reduces the production of antibodies to the molecule that you're using, and it gives dual benefit regarding disease activity control and efficacy of the biologic.
In this case, there isn't contradiction between the two.
No, there isn't contradiction. You have the free hand, even in the ACR publications lately, you can use a single hand biologic in rheumatoid arthritis without conventional DMARDs. It's up to you, or conventional disease-modifying drugs. It's up to you. But I tell you from practice, and it's there in the literature, in the case reviews, it's better to combine. Better to combine, unless your patient is refusing to use a lot of drugs. Okay, thank you.
Well, thank you very much.